Hi, and welcome back to JNO Network Open Live. I'm Seth Truger, Digital Media Editor at JNO Network Open.
And I'm Angel Desai. I'm the Fishbein Fellow here at JAMA.
Great. So our first paper today is Trans and Racial and Ethnic Representation Among U.S. Medical Students by Linaire Ahmad-Lett and colleagues. So this is an interesting paper. They looked at the rates of representation by different minority groups in applications and matriculation at U.S. med schools from 2002 to 2017, how those changed over time, and more importantly, how those also changed in the context of the changing demographics of the U.S. as a whole. And it's really interesting.
Yeah, definitely. And they use something called the representation quotient to actually get at that. And that was essentially the ratio of a particular subgroup among the whole population of applicants and matriculants relative to that corresponding subgroup in the U.S. population, which is kind of neat.
Yeah, and interestingly, the context for this is this is basically like a bad news, good news, bad news paper, I think is probably the way I would look at it. Traditionally, underrepresented groups have been underrepresented in med schools, not surprisingly. The LCME, the Liaison Committee on Medical Education, which is the big accrediting body, has been working with med schools, and med schools have been working and taking a lot of positive steps to try to increase representation of underrepresented groups in a lot of different ways, and this has trickled through to a lot of different institutions, med schools, residencies, hospitals in general, leadership, et cetera. And what's interesting is basically the bottom line is that the rates of underrepresented groups have been improving over years as a whole. So in absolute terms, the relative representation has gone up, if that makes sense.
Yeah.
The bad news is because of the changing demographics in the U.S., which is becoming more, the minority populations are getting bigger, which is not bad news. The overall what they call it, the representation quotients have actually been getting worse. So I think if I understand it right, it's like walking on a treadmill, walking on one of those people movers, the moving sidewalks that they have at the airport. So I'm behind, I'm walking faster, but I'm not catching up because the treadmill is moving even faster against me. Does that sound right?
I think that sounds right. And I think one of the really interesting things too was when they looked at the particular subgroups, and I think specifically African American women were one group where there's really not been a lot of representation in, I think, both the applicants and the matriculants, but specifically in the matriculants. As well as a variety of other subgroups.
Yeah, and we can look. Show Figure 1 shows the representation quotients by race, ethnicity, and sex for applicants from 2002 to 2017. The break that you can see in the chart there is only because the methodology of how they collected the data changed in 2012. They basically allowed more the selection of applicants to define as more than one group, and change the way that identifying as Hispanic could work. So that's not really a change there. That's just a gap because of different methodology. So the good news is one of the things I found that was promising here is that the applicant graphs and the matriculant graphs were very, very similar. This is not necessarily a problem of like worsening discrimination at the med school admission committee level or anything like that, which could certainly be a problem, but doesn't seem to be, which is nice. And the numbers are pretty parallel. But then if you look at Figure 3, they do these color maps. They call that, was it chloroplex?
Yeah.
I'd never heard that term before. It was pretty cool. But basically, these maps take this representation quotient, which, as you described, is really intuitive, just simple fraction comparing the percentage of the med school versus percentage in the state, and then these colors, the dark blues and green, the dark blues and dark colors are states that are below their representation, below 1 by ethnicity. So the top corner, it's let's see, Black, white, Hispanic, Native Hawaiian or Pacific Islander, Asian, and I forget what that one is. American Indian or Alaskan Native. And then the colors that are brighter, like the greens and yellows, are overrepresented groups. So basically, for the most part, it's the top graph in the middle, where whites are mostly overrepresented. There are a couple spots where that are a little different. New England's a little different. I think some of that's just artifact of small cell size. So like New Hampshire doesn't have a lot of med schools, doesn't have a big population, has, I'm pretty sure as far as I know, without making too many generalizations, not a lot of certain underrepresented groups. So you get a few underrepresented groups in med school over the average, and the quotient shoots up.
Right.
So still good news, but
yeah, definitely really interesting and important. I think there's a lot of policy implications implications in there as well.
Yep, and there's a good accompanying invited commentary that gets into some of these issues and what's been going on. Again, this is one of those issues where there's a lot to talk about. Not everything. It's not all good. It's not all bad. There's a lot of things that are dynamic in a bunch of different directions. I'll say I went to a med school that at its time was, I'd say, behind the curve in representativeness, and this school has taken a number of positive steps to get a lot better about recruiting minority students, and the numbers have certainly caught up to a lot of peer schools, which is good. Yeah. My residency institution did that as well, and a lot of it is, and his papers that we've talked about before in the show, things like going into underserved communities, talking to high school kids, getting people much earlier in the pipeline.
Yeah, definitely.
Yeah. Other thoughts?
No, I think really interesting, and everyone should check it out.
Yeah, really great work here. Really important stuff to make sure that we're getting a workforce that's representative of the country so that people can get care. All right, so moving on, we are doing another big table of contents because we've got lots and lots of papers. So first one up, this is another really interesting kind of different style paper than a lot of what we're used to. But they looked at the association between childhood history of parental incarceration or involvement by the patient themselves in the juvenile justice system. And tracked the kids to see if there's an association between that and mental health in early adulthood. These the Ad Health survey is 12,000 kids, grade 7 to 12, in 1994 through 1995. So actually roughly my age, who are 24 to 32 at follow-up in 2008. 80% of them had no involvement in the criminal justice system, either their parents or themselves in the juvenile justice system. Rates of, I think it was 9% had childhood parental involvement incarceration, or 9% parental incarceration, 5% who had parental incarceration after 18, and another 5% who were involved in the juvenile justice system. And the rates of depression were, or mental health problems were non-trivial. So 15 to 25% depression, 12 to 18% anxiety, 2 to 6% PTSD, and not surprisingly, the involvement in the criminal justice system, especially with the parents, did increase the chance there was a positive association with mental health in early adulthood. Not huge. The adjusted ORs were 1.8, 2.5, that kind of range. And it wasn't, it was actually kind of like simple and additive and not synergistic, which was actually kind of surprising.
Yeah, I was surprised about that too, because it looked like independently there were this increased risk, but the two together actually didn't necessarily demonstrate that. And they did control for socioeconomic factors in this as well, so I think that made a difference. And the other thing that I thought was really sort of astonishing was this number that they mentioned: 1 in 100 U.S. children have either parental incarceration or some sort of juvenile justice involvement, which I thought was astronomical.
Yeah, absolutely. And also, I'm certainly not an expert in these stats, but as a whole, our country, we have the, I think, shameful position as not only having the highest per capita rates of incarceration, but we actually have the highest numerical rates of people who are in the criminal justice system. So even though we're, a quarter the size of China, which, has some criminal justice and rights issues, we actually have more people in our criminal justice system.
Wow.
I mean, it's not all apples to apples, because a lot of that's people who are, say, on parole or, not in labor camps or things. But it's tough stuff. And it's one of those things that's a little, again, I think one of the glimmers of hope is as we're seeing things like the change in political discussion about criminal justice reform and things like that, we've seen really vast change in the last few years about how we talk about such things, that knowing that it's the kind of thing that can potentially impact people's mental health in the future.
Definitely.
That's good. Yeah. All right, moving on. Next up, association of exposures to diagnostic low-dose ionizing radiation with the risk of cancer among youths in South Korea. So they looked at the South Korean health system database, where they have all the data on everybody, looked at everybody who's 0 to 19 in the database, and basically looked to see if people who got low-dose ionizing radiation, things like CAT scans, fluoroscopy, like upper GI urography or bone scans, were more likely to be diagnosed with cancer. They left a 2-year lag period between when they got the imaging and when they got the diagnosis of cancer, so which would not eliminate but minimize the chance that it was, the first scan for symptoms that would eventually present as the cancer, which I think to me passes a bit of the sniff test.
Definitely, and the sort of the first exposure, was between the ages of 0 and 19, correct?
Yep, absolutely. And we've got the visual abstract for that, and you can see a couple things that the the rates of cancer, the IRRs were again in the order of about 2 for most things. The similar rates to solid and liquid cancers, things like breast cancer, thyroid cancer, mouth and neck cancer, and of course myelodysplasia, stuff like that. And if you look at what type, the different scans, there's some interesting tables in the supplemental appendix that look at which different scans are associated with which different types of cancer. Interestingly, abdominal CT led to breast cancer.
Yeah, that was surprising.
There's overlap between the thorax and the abdomen.
Yeah.
Not surprisingly, spine and neck CT leads to thyroid and head and neck cancer. Bone scans, which give you kind of whole body radiation, have decent risk for liquid cancers. So.
Well, when I was reading this, I thought the liquid cancers that made sense, but the solid ones, the breast and the thyroid especially. But as we're talking about now, I think it does make sense in terms of the abdominal and kind of where the scans are happening.
Yep. I mean, again, the good news here is that the rates of cancer are still pretty low. It's just increased if you got radiation. And the authors do have a really, what I think is a really nice discussion about the potential for reverse causation here. That it just might be that even 2 years before, what you're having symptoms of might be of what's eventually your cancer.
Yeah, absolutely. I don't know, I don't think I saw it here, and I'm not sure if you know, but just thinking about sort of the overuse of imaging, I'm not sure if we know about it in this context, but certainly it's an issue elsewhere, at least in the U.S.
Yeah, I mean, I'll put that in my box of there's lots of things that are downsides about over-testing, and even if, the best estimates we have that, a CAT scan leads to about probably a 1 in 2,000 chance or 1 in 1,000 chance of increasing your risk of cancer down the road, more than 1,000 people get scans by a few orders of magnitude. So, so the more we can do to reduce unnecessary imaging, the better.
Definitely.
As always. Good. Of course, it's finding unnecessary. That's
yeah.
All right. And this next one, this one's really interesting. So these researchers looked at long-term cardiovascular disease among firefighters who were helping in the World Trade Center disaster on 9/11, which tomorrow will be the 18th anniversary.
That's right.
They basically grouped the firefighters into a couple different exposures. So whether they were in the first wave in the morning who came, if they were in the afternoon on 9/11, the next group was on 9/12, and the last group was anybody who came on days 3 through 14. Followed them over time and basically found that the rates of cardiovascular disease were not small. So their average age was 40. And in the follow-up period, there's 489 of the primary outcomes, things like stroke, MI, unstable angina, PCI, CABG, cardiovascular disease related deaths. Only a quarter of them smoked. They had something like 120 MI, 60 strokes, 300 CABG PCIs. And not surprisingly, there was basically a dose response rate where the incident rates were basically 5 to 3 to 2 as you increased exposure, with a hazard ratio of 1.4 in the early groups to the later groups.
Yeah, and I really, they mentioned at 1.2 that the hazard ratio of the highest versus the lowest exposure was actually comparable in magnitude to hypertension, which we know is a huge risk factor on its own for cardiovascular disease. I thought it was kind of interesting.
Yeah, and it's interesting, when things like this happen, it's hard to get really good data and to really know exactly what's going on, just because, fortunately, disasters like this aren't that commonplace. Even though it's 18 years later, there's still all sorts of, continuing fights. Congress was just talking about this sort of thing a few weeks ago about how benefits for, workers for this sort of stuff works. It's complex stuff, so it's good to have good data on it.
Definitely. I was thinking a little bit about this because I know that this group has been looked at in the past in terms of respiratory illness. I was trying to understand cardiovascular disease, how that all fit in, but I think there's a lot of things that we don't really understand.
Yeah, who knows? I mean, some of it might be direct things like exposure to dust, inhaling. Who knows what type of things people are inhaling. Particulate matter, et cetera, leads to either direct harm. It's interesting to me. I remember a few years ago for a project I was looking into the data on health outcomes from oil spills, and all the best data is about mental health related problems. Yeah, and basically depression, things like that, which is probably more second order from loss of home, disruption in the local environment, the economy, et cetera, than oil makes you sad, or not sad, but clinically depressed. But it's really interesting. So it's kind of interesting to see, somatic disease.
Definitely.
Like this. All right.
All right.
All right, moving on. This one's another very interesting, slightly complex paper, The Association of Race and Ethnicity with Emergency Department Destination of EMS Transports. So this group from Boston University, they looked at 860,000 Medicare enrollee EMS transfers to EDs by zip code from 2006 to 2012, and then basically looked by race, white, black, or Hispanic, and they defined any zip code, the hospital that I guess was the most common hospital that white patients went to as by EMS as the reference hospital, and then compared how that worked with the different racial groups, and basically found that 60% of whites were transported to reference hospitals, and there was differences where 5% fewer black patients and 2.5% fewer Hispanic patients were taken to the same hospital. Some of it is certainly or may be related to things like patient choice, where they go to hospitals that they're used to going, that they're plugged into outpatient care, et cetera. Some of it might just be simple geography of where people live and where hospitals are distributed in zip codes, but some of it might have to do with certain, all the types of disparities and implicit biases that we see in everything. There were slightly higher transport times to the other hospitals. Similar kind of, the exact kind of differences you'd expect in who was transported to safety net hospitals. And one of the checks they did to see that the data were robust is that it was the same difference in transport with high acuity transports. So things like stroke activations, STEMIs, et cetera, still went to in basically the exact same proportions to the disparate hospitals.
I thought I was going to mention that actually. I thought that was really, I know you got it. It's okay. I thought that was really interesting, and I think you mentioned it too, just the fact that Black and Hispanic patients overall were more likely to be transported to safety net emergency departments compared to their white counterparts that were living in the same zip codes. And the other thing that I thought was interesting, just from a methodological perspective, is they note that previous studies have made mention of the fact that when you look at Medicare data, there's sort of a poor sensitivity for using race and ethnicity specifically. And so they also use surname-based sort of imputations to try to fill in some of those gaps, which is sort of unique.
It's really interesting stuff. And again, this is, this isn't the only study that's looking at these sort of health disparities. So it's one more piece, and studies like this are great for kind of helping us flesh out exactly how these kind of, potential implicit biases impact our care for patients.
And this is in your wheelhouse too, right?
I don't do any EMS work, but the ED stuff's always interesting. And we're always happy to take care of everybody. And they did some interesting stuff too, which I can't remember all the details of, and I can't pretend I understood it all, of how of how walk-in patients compared to, as again a nice almost a sensitivity analysis.
Exactly.
All right, what do we have next?
All right, latent tuberculosis infection testing strategies for HIV-positive individuals in Hong Kong. So this was a decision analytical model that looked at how cost-effective is testing for latent TB in HIV-positive individuals that have a negative latent TB test result at baseline. And sort of this is coming, just to take a step back, this is sort of coming from the perspective that we know that individuals with HIV are at risk, a greater risk, I think they quote here, 26 times more likely to develop TB or reactivate latent TB. But with the advent of better antiretrovirals, potentially this risk may not be as great. And so they used data from some clinics in Hong Kong, and they found that out of 3,100 patients with HIV, 94 went on to develop TB, and that ultimately testing HIV-positive individuals is not, at a regular sort of almost excessive interval, is not necessarily cost-effective compared with less intense testing. The caveat of that being that we also need to make sure that the coverage for baseline LTBI or latent TB testing and subsequent treatment is in effect to be able to make that true. And a couple of things that they sort of recommended towards the end of the paper were thinking about administering risk-based testing, so individuals that are at greater risk for developing TB or that are in constant sort of exposure with high-risk individuals, as well as just sort of overall limiting the number of yearly tests by focusing on these groups.
Yeah, that's really interesting. I mean, and again, it's the kind of thing where it seems easy to just do blanket testing or annual testing for higher risk patients. But if they're showing that it's basically almost like a biopsy, if you get 4 years in a row of negative testing and your risk profile doesn't really change, then more testing isn't worth it. That's great.
Definitely, and I think, certainly thinking about this from a diagnostic stewardship perspective too makes a lot of sense, and definitely will give me something to think about moving forward. Okay, so next up, self-reported rates of abuse, neglect, and bullying experienced by transgender and gender-non-binary adolescents in China. So this was a national online survey in China in 2017 that looked to assess rates of bullying and abuse experienced by Chinese transgender and gender non-binary adolescents, and sort of what the associations of those experiences were with mental health outcomes. And so they ended up having 385 respondents. 92% of those reported parental abuse and neglect, and these are the individuals who stated that their parents knew their gender identity. 76% of all of the individuals surveyed did recount some sort of abuse or bullying due to being transgender or gender non-binary from their classmates and teachers, which is huge. 44% were at risk for major depressive disorder, and 38% were at risk for anxiety. So, and they do go in the discussion a little bit about how this is comparable with other surveys that have been done in other countries, but definitely a huge issue. This is certainly an underrepresented population in research as well, so something I think to think about.
Yeah, and it was one of the things that was just fascinating for me was how it was the rates of abuse or bullying from classmates or teachers.
Yeah, I couldn't believe that.
Yeah, I mean it's one of those things where I hadn't really thought about it, but it is absolutely plausible.
Yeah.
And very sad.
Definitely.
And again, I'm still an optimist. There's lots of room for improvement.
Yes, definitely.
All right, we got one more paper.
Yes. So this is the assessment and comparison of hepatitis C viremia in the prison systems of New Mexico and Georgia. And this was a paper that came actually in response to a prior study that had looked at NHANES data to estimate the prevalence of hepatitis C among individuals in the criminal justice system. And the authors note that the concern with the way that this data was presented was that other sources of data were not necessarily looked at, and there are sort of variables or variances among states. And so they did a cross-sectional study that looked at Hep C antibody and sort of having Hep C antibody positivity as well as viremia, and the prevalence of that from individuals that were entering the New Mexico Corrections Department and individuals exiting the Georgia Department of Corrections. And so they found that of those, the prevalence of those entering New Mexico Corrections Department was 40%. Of Hep C, and Hep C viremia for those exiting the Georgia Department of Corrections was 6.1%. And this was different from what had been estimated from that previous study. And so ultimately the authors sort of recommend considering sort of state-specific data, because that's a pretty big difference between the two. And they do note, they only look at these two states, but it is sort of a call to look at more granular data to consider this.
Yeah, and one of the things that was fascinating is when they're noting their background information that there's about 11% rate of Hep C in prevalence in the U.S. as a whole, which for one is just very high.
Yeah.
But there's also, they know there's about a 5 to 6-fold state-to-state variation, and this is basically a 10-fold variation in prevalence between these two subpopulations that have high, essentially higher than average the rates at all. So it's really fascinating. Obviously, the patients in the criminal justice system have more risk factors for Hep C exposure. But again, this stuff that's fascinating, and especially since now it's been a few years that we've actually had treatments available for Hep C that are seem to be curative.
Yeah, definitely.
That it's recognizing this as just something that people have and something that we can do something about is really fascinating.
Definitely, and an opportunity for us as clinicians to be able to act.
Yep, absolutely. All right, so thank you so much for joining us today. We will be back next Tuesday at 3 o'clock again, Central Time. Read these papers and more at JAMA-NetworkOpen.com. Follow us on your usual social media channels, Twitter, Facebook, Pinterest, LinkedIn at JAMA Network Open. And our new releases come out Wednesday and Friday at 10 a.m. Central Time. So check out our new papers this week.
Thanks so much, everyone.
Great. Take care.